In this Medical Observer procedural update, we join Dr. Doran Scher, orthopaedic surgeon specialising in knee and shoulder surgery.
Today's patient is in her late 80s. She has known osteoarthritis of her knees but wishes to avoid total knee replacement. We have already maximised her analgesics in terms of paracetamol and anti-inflammatories, and she has had physiotherapy. Today she chose to attend for injections of both knees with 5 mils of 1% xylocaine and 1 ampule of celestone into each knee. The medial approach to the knee with the patient seated was utilised. This is the knee joint, the medial side of the knee, patella, patella tendon, medial femoral condyle tibia, and so we can see that's the soft spot that we're going into. So we drew these lines to mark out where everything is. Having entered at this point here, if I go straight, I'm going to hit the medial femoral condyle. If I drop my hand, I'm going to hit the tibia. If I go too far medially, I'm going to hit the patella. So you need to go in through that soft spot and slowly change the angle so that you're heading into the intercondylar notch, where there really is a huge amount of space and there's nothing that you need to worry about. So you put your needle in, angle, inject, 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 inject. It will suddenly get to a point where you lose resistance. You inject the rest of the local, leave the needle there, change syringes to the celestone syringe and inject that, and that's the end of the injection. There are several ways to inject a knee joint. You can inject laterally, medially, or with the patient supine. My preference is to have the patient sitting comfortably on an examination couch, and this is particularly important. If they have a vasovagal, they can just simply lie down straight away. That's why I prefer not to do it in a chair. In terms of where to inject, I prefer injecting the medial side. And you see the anatomy here with the patella tendon, and I've marked where the medial femoral condyle and the tibial plateau are. That gives us a nice area where what we call the soft spot is, and that's the point there that we're going to inject. I will then mark with my nail where the soft spot is. And I put an indentation there so that after I've used my prep, I don't rub off any pen marks that I have. I now have a nice indentation, and then the patient just needs to relax their leg to drop back down to 90 degrees. Now it's very important to use strict aseptic technique here, so I'm going to prep the area and then put on sterile gloves before I give my injection. So you can either use chlorhexidine, betadine, or an alcoholic version of either of those, and it's important obviously to allow drying time for that solution to make sure that the patient does not get an infection from this procedure. So while I'm waiting for the betadine to dry, typically I'll draw up my local anaesthetic. I use 1% xylocaine and I use 1 ampule of celestone for my injection. I inject with a local anaesthetic first, which I'll demonstrate, and then once I'm inside the capsule, I then inject the celestone. Just relax your leg again for me, and it's important that the patient's leg stays at 90 degrees. Now this is the painful part, it's the local anaesthetic. So what you'll feel is a sharp sting, and then as the local anaesthetic goes deeper into the knee, the needle will travel, but the pain should go away after that initial sting. Sharp sting, and I inject just a little bit of local anaesthetic into the skin as I go. Just relax the leg for me. Where I'm aiming now is into the intercondylar notch, and I proceed by just injecting a little bit at a time as I go deeper and deeper and deeper into the joint, and eventually you'll either feel a pop or just a complete loss of resistance, indicating that you're now inside the capsule. Leave the needle where it is, and I change to my celestone syringe, and then inject again without any resistance whatsoever. In this situation, there's not much point aspirating because there are no major neurovascular structures in the area that you could be injecting into a vein. However, if you suspect that the patient has an effusion or an infection, you would certainly aspirate before you injected a corticosteroid into the knee. Having completed the injection, you then want to apply some pressure to the area after having taken the needle out, and that pressure should be applied for at least 1 minute. Having applied pressure for a minute, I then apply a Band-Aid and ask the patient to apply pressure for a further full 60 seconds. This reduces swelling and bruising and reduces the level of pain for the patient. It's important also to give the patient specific post-injection instructions, explain to them what to look for in terms of an infection or a corticosteroid flare, and I ask them to rest for the rest of the day and put ice packs on the knee as much as possible.
You've been watching another Medical Observer procedural update. Medical Observer brings life to medicine.